Hello, everyone, and welcome to the April issue of DermSurgery Digest. I am Michael Renzi with Lexington Clinic Dermatology, co-host of the podcast. This month, we are excited to premiere our updated format, which will separate the surgical oncology and reconstruction portion of the Dermatologic Surgery Journal into two 30-minute episodes. This episode, which we are calling Rapid Clinical Pearls, will briefly cover the clinical application of the data from each article not covered in our Spotlight episode. Our goal with this format change is to make the content more digestible with a focus on clinical application and enhancing patient care. Our feature editors for this episode are Caresse Gamret with Genesis Dermatology, who will be providing the article summaries, and Sherrif Ibrahim, assistant professor in the Department of Dermatology at University of Rochester, who will be offering the expert commentary. Thank you for listening. We hope you enjoy this new format, and as always, have a happy surgery day.
Welcome, Dr. Sherrif Ibrahim, here to discuss the April 2026 edition of Dermatologic Surgery. Today, our session is centered more on rapid review and clinical pearls. So I look forward to hearing your takeaway on some of the articles to be discussed. I'm Caresse Gamret, and without further ado, we will go ahead and get started. Our first article to discuss is Atypical Fibroxanthoma, Trends and Insights from a Single Tertiary Care Institution over a 10-year span by Humeda et al. Atypical fibroxanthoma, or AFX, is a rare spindle cell tumor that can be challenging to distinguish from more aggressive entities like pleomorphic dermal sarcoma, or PDS, a distinction that's critical given the differences in prognosis. This retrospective study reviewed 108 patients with 113 AFX tumors over 10 years, along with 5 cases of PDS, including 2 cases where AFX progressed to PDS. Clinically, the findings were what we expected. Elderly patients, predominantly male, with tumors most commonly on sun-exposed areas, especially the scalp. Notably, nearly 70% had a history of prior malignancy. From a treatment standpoint, Mohs surgery was used in over 98% of cases, with about 43% clearing in a single stage. In terms of outcomes, recurrence was relatively low at 3.5%, and metastasis was rare. However, the key point is that AFX can recur and in some cases progresses to PDS, which carries a much higher risk of metastasis and mortality. Importantly, this progression occurred even in some immunocompetent patients, although we know immunosuppression remains a risk factor for that progression. What's the takeaway here? While AFX is generally considered a low-grade malignancy, it requires careful histologic evaluation, especially of the deep margin, as well as close follow-up, given the risk of recurrence and potential progression to PDS. Dr. Ibrahim, is something a progression from AFX to PDS something that you've seen clinically, and what sort of tips you off that may be the case?
Oh, it was definitely, and recently, as a matter of fact. Original biopsy was AFX. We cleared it with Mohs, and then he was back very, very quickly with an obviously deeply invasive tumor, and we did imaging, and it had already, invaded into the bone. What you said is totally true, right? AFX is a low-grade malignancy in most cases, but it also reinforces that not all of these lesions behave in this sort of indolent way, and that key distinction is between AFX and pleomorphic dermal sarcoma. That's really where we see this divergent behavior. Margin control is critical, but even some of these tumors that we see in Mohs, and they clear and they just have another aggressive biologic undertone to them that it's unforeseeable which ones do and which ones don't. Luckily, most of them don't progress, but it's usually larger tumors, deeper invasion, aggressive behavior, meaning they recur quickly, immunosuppressed patients, of course. And it happens. I mean, when you're in practice long enough, you're going to see it for sure. So just keep an eye on these patients.
Absolutely. I definitely feel like this is something to keep an eye on, that you, as a earlier in your practice, dermatologist and Mohs surgeon, you might not be as keen to watch. Is there something that, looking back at that recent case you were thinking about that tipped you off besides the fact that he just seemed to come back with recurrence so quickly? I mean, I know they talk about how you can certainly have, a difficult time diagnosing PDS with these shallow biopsies, because oftentimes, as you mentioned, there's like a deeper component, oftentimes with a lot of necrosis. Um, Going into a Mohs case, is there something that you might see about an AFX where you would say, hey, let's pause, let's make sure we have the right diagnosis here? Or how do you approach these?
Most of them are on the scalp. So again, larger, deeper, or patient characteristics. You may want to consider getting imaging beforehand. Once you get into it with Mohs, this histology is challenging. You get these very tiny, tiny little wispy cells, oftentimes deep into the fat, and it's difficult to distinguish them from lymphocytes sometimes because they're just so tiny and sometimes uniform, sometimes not, sometimes round, sometimes spindled. So just, when in doubt, take an additional stage. If you feel like you've cleared it, potentially go down to the periosteum just to get that galeal layer, just even if you don't see tumor in there, as a safety precaution, just to minimize the chance of anything being left behind that you just can't see on your Mohs stage. So again, we don't see even a ton of AFXs, maybe a handful a year, maybe, I don't know, 20 a year of AFXs, and maybe one or two of those behave badly. So definitely the vigilance is peaked, I think, more recently because of all of the discussion we've had as a specialty about this differentiation between AFX and PDS, and trying to catch these patients early and follow them more closely when they have those high risk features.
Yeah, absolutely. I think that, keeping vigilant, as we've kind of touched on, in other discussions this month, is certainly going to be important for these patients. Next, we can talk about early takedown of interpolation flaps, as prompted by an article entitled Early Takedown of Postauricular, Melolabial, and Paramedian Forehead Interpolation Flaps, a retrospective cohort study by Naomi Lawrence's group. Traditionally, these staged flaps are divided at around 3 weeks to ensure adequate vascularization. However, that delay can significantly impact patient comfort and quality of life due to the presence of an external pedicle. This retrospective cohort study evaluated early takedown, defined as less than 21 days, versus the conventional takedown at 3 weeks in 141 patients across the 3 flap types. The key finding was complication rates, including infection, dehiscence, and flap necrosis, were low and showed no significant difference between early and standard takedown groups across all flap types. Importantly, this study adds evidence supporting early takedown of postauricular flaps, an area where data has previously been limited. Clinically, this suggests that early takedown of interpolation flaps, including postauricular, melolabial, and paramedian forehead flaps, appears to be safe, effective, and may improve patient comfort and quality of life without increasing complication risk. In your practice, how often are you doing these interpolation flaps, and what is your sort of magic recipe for success with them in regards to planning that second stage?
We don't do a lot of them, mostly because a lot of our patients come from far away. They're farmers. They're not interested in having 2 procedures. So really not that often. It is nice to have this data though, right? There's this dogma of 3 weeks, and we all know that things don't necessarily always fit into scenarios perfectly, meaning your schedule, the patient's schedule, weekends, things like that don't always line up perfectly. So it's just nice to have the data that backs it up, that if you have to shorten it a little bit, you're generally going to be okay. I mean, that being said, less than 21 days could have been 20 days or 19 days, right? So it's not 1 week or even 10 days. It could be just 1 day short of that 3 week mark. I mean, this is not setting a new standard or going against that dogma. It's just making us feel okay if we're in this situation. A selective opportunity given the right patient, if you have to do it. Of course, if they're a smoker or any kind of compromised vascular situation, you're not going to do it. But in carefully selected patients or in certain situations where you're kind of pushed to do it, it's just nice to have the data to back you up to say, you know what, you're probably going to be okay.
Yeah, absolutely. In general, there have been articles published in a similar vein, but the post-auricular flap, I don't feel like has been as highlighted in the literature. So that was nice. When you do these two-stage flaps, is there anything day of that makes you say, oh, wait, what's going on here? Maybe we should let this mature a little bit further, or anything that makes you feel really confident, like, oh, well, this is taken great, like venous congestion, particular like scabbing. Tell me what you're looking for clinically on the day of that gives you a thumbs up to proceed with pedicle takedown.
Oh, so you're referring to the day of takedown.
Yeah.
We just look for good perfusion. You can just blanch the flap, squeeze on it, and make sure that it perfuses well. And most of them, if not all of them, it's pretty rare to have one of these fail, are good to go at that 3-week mark. The question is, what would it look like at 2 weeks or shorter than that? And, it's going to be those same clinical feedback tests that you can do, looking for good perfusion. It is pretty rare to have one of these flaps fail when you have a nice supportive pedicle and it's executed the right way. But
Yeah, absolutely.
we're going to talk about one later that maybe didn't turn out as good.
Absolutely, we will. I could see from a patient perspective, though, I mean, 3 weeks is a relatively short period of your life, but to have your forehead connected to your nose and you're walking around like that, certainly, I mean, like you said, doing it for less than 3 weeks, I would find that some patients, would be a little bit comforted by, like, oh, I can just hide out for 2 weeks, or however many days, less than 3 weeks it is. But 3 weeks does feel like a long time if you are in some of those situations, particularly for probably melolabial and paramedian forehead flaps. I find that retroauricular flaps tend to be, much better tolerated by patients.
Yeah, you make a really excellent point that's, I think, important to touch on is it's not just the sort of social downtime of having it, but a lot of our patients have trouble caring for it, where we're saying, put a wick behind it, clean it out. They don't want to touch it. They don't feel comfortable doing it. So we see those patients frequently to do it for them. And those might be a good type of patient to take the flap down a little bit early when they're just struggling with it and they're not comfortable with it and it makes them nervous. We see those patients all the time. So that's an excellent point, just sort of the patient factor of getting it done a little earlier.
Absolutely, kind of moving on along. Speaking of moving on along, next we will speak about an article entitled Divergent Functional Outcome Measures for Perioral Surgery Across Clinical Indications, a systematic review by Patel and colleagues on functional outcome measures in perioral surgery. The perioral region is critical for speech, eating, oral competence, and facial expression. Yet this review highlights a major gap in how we assess these functions after surgery. Across more than 100 validated tools, functional outcomes were surprisingly underrepresented. While about half of oncologic and reconstructive tools included functional measures, only 2 out of 55 cosmetic tools assessed function at all. Most cosmetic scales were focused almost exclusively on aesthetics. When function was evaluated, the scope was narrow, typically limited to speech, eating, or smiling, with no single tool capturing the full range of perioral function. This has real clinical implications as cosmetic procedures around the lips continue to rise. Failing to assess function may overlook subtle but meaningful impairments in movement and expression. The takeaway, we likely need more comprehensive perioral specific assessment tools that can integrate function, aesthetics, and quality of life, especially in cosmetic dermatology. Are these tools something that you are using clinically or taking into account when kind of coming up with repair options for the perioral region from both a reconstructive perspective after Mohs surgery or also, potentially elective surgical procedures that you may be performing?
Yeah, I mean, I think what the authors are saying here is saying without some sort of standardization of outcome, it's hard to say that one reconstructive approach is better than another. Cosmesis is important, but things like speech and symmetry, oral competence, things like that are not being measured, and certainly not in any kind of uniform or unified way. So I think this is like less about technique, but more about the framework we use to evaluate those techniques. And I think that they're sort of a call to order to come up with a more objective metric to compare these different approaches.
Yes, definitely. And also just bringing attention to the fact that they aren't being, measured. Maybe they also aren't being, appropriately prioritized. And who's to say if one repair is going to help with oral competence, or that patient who's, really prone to like candidal infections at the corner of their mouth, or how to sort of take into account how patients may have existing deficits with their oral competence and what may optimize potentially someone who's prone to a specific, deficit in that factor. But yeah, definitely was highlighting the fact that we do not have a good way to sort of put our finger on and get a metric for these. Next, we're moving on to ingrown toenails. We are reviewing a study on the modified Heifetz technique for treating ingrown toenails by Ozel et al. This retrospective analysis compared 214 patients undergoing either the classic Heifetz procedure or a modified version that introduces a key change, a transverse suturing technique that avoids passing suture through the nail plate itself. The results are clinically meaningful. The modified technique reduced recurrence rates from 10.6% down to 2.7%, while also significantly improving cosmetic satisfaction, 96% versus 79% for the non-modified technique. Post-operative pain was also markedly lower, with near zero visual analog scale pain scores, and patients returned to activity slightly faster. Importantly, the modification addresses a known limitation of the classic technique, nail plate distortion and pain from sutures through the nail plate, while still ensuring adequate matrix destruction. Complication rates, infection rates were similar between both groups. The takeaway, this simple technique adjustment may offer better outcomes across recurrence, pain, and cosmetics, making it a strong alternative for stage 2 and stage 3 ingrown toenails, though prospective studies are still needed. Is this a procedure you do with any frequency, and any thoughts about this? When they pointed out these modifications, it seemed very intuitive to me that, yes, why haven't these always been done this way? And I found that their supplemental video showing how to do these procedures was really helpful when reading this article.
Yeah, a really nice example of how just a small modification can improve outcomes, especially around healing and, a residual wave in the nail plate, things like that, that patients don't necessarily want. The key with ingrown toenails, we don't do a ton of it, but when you do, in order to do it right, it's all about that adequate matrix destruction, and removal of the lateral edge of the nail plate. So, to me, it still comes down to that technique so that they don't have this little spicule of a nail that comes back that bothers them almost as much, if not more, as the original ingrown nail. So a nice improvement of to hopefully improve outcomes over time. But again, focus on that matrix destruction, I found is the most important part.
Yeah. And when you're doing those destructive matrix techniques, is that for you looking like you're just making sure to really get around it with the scalpel, or adequate, hyfurcation, or are you using any sort of chemicals to do this? I know there are quite a few different ways that you can kind of skin a cat.
We, no pun intended, right? We use phenol and very high setting hyfurcation. I do both. And the key to me is to get really in that lateral pocket. most of us don't realize how far laterally those ingrown toenails can really extend. So I use a skin hook to lift up the corner of the proximal nail fold and really dig back in there in order to prevent any recurrence laterally. And then there you have this skip in nail, and that really bothers patients when it comes back.
Yes, absolutely. I similarly am not doing a great deal of these nail procedures, but certainly it's good to know how to do them appropriately when those patients do seek our help. Some excellent pearls here to ensure great patient outcomes. Next, we're reviewing a single center study evaluating treatment outcomes in dermatofibromatosarcoma protuberans, or DFSP, from Lauren Council's group. This retrospective analysis of 133 patients compared standard excision, like wide local excisions, with margin-controlled approaches, including Mohs micrographic surgery and other peripheral and deep NFOS margin assessment techniques. The key finding was that local recurrence was 0% with margin-controlled surgery versus 15.8% with standard excision, despite similar rates of margin negativity. Importantly, margin assessment cases also resulted in smaller post-operative defects, highlighting the tissue-sparing advantage. Interestingly, overall survival did not differ between these groups. This reinforces that DFSP is typically low mortality, but recurrence remains the most clinically meaningful outcome. For standard excisions, margins also matter. Lesions treated with greater than 2 centimeter margin showed a substantial, though not statistically significant, reduction in recurrence. Here, this really emphasizes that complete margin assessment is critical. And when available, Mohs or peripheral and deep NFOS margin assessment should be first line. If not available, wider margins and re-excision for positive margins are essential to minimize recurrence risk for these patients. Obviously, we are both Mohs surgeons, so I think we would both argue that, yes, Mohs surgery is obviously the gold standard here, as much of the literature suggests. But I did find it interesting that it mentions that there really isn't too much of a difference between survival in these groups, despite the fact that the recurrence rates are differing here.
Yeah, I mean, I think the main takeaway here is pretty straightforward. Complete margin control is a key determinant of outcome when it comes to treating DFSPs. I couldn't imagine doing anything other than Mohs for these. I've given up trying to predict how much subclinical spread they have. Sometimes you say, oh, this is going to be a bad one. And, I kind of like have a talk with the histotech before we start, like, hey, this is going to be bad. And it's not, or vice versa. It looks like a tiny one and it goes several stages. So, they're low grade, but they are definitely locally aggressive. So recurrence is a function of how well you clear it that first time. So we are really careful with our Mohs sections. I tell the histotech, freeze this like as solid as you can, go to lunch, and then come back and cut it, because those deep fat layers are so critical, and we don't want to have that fat dropout that sometimes we see if things are processed a little bit too quickly before freezing very well. So that to me is more the most important margin, is that deep fat margin. So do a good job the first time and they won't come back. And then we often will take even like a final additional just debulk stage, even when we don't see anything on Mohs. That final Mohs stage is clear, I'll still take another layer of just fat, and you can even send that for permanence just to make sure.
Absolutely. And then in terms of your first stage for these cases, is there a specific depth that your sort of experience has told you need to get down to sort of really ensure that you're, not taking so many different stages? Or what's your approach for that when you're staging?
Yeah, I mean, it depends where it is. Sometimes, like we just had one on the back of someone who had a thicker adipose layer. So, and then sometimes they're on an arm where it's just really easy to just take it. If I can, I just take it to fascia on the first stage.
Yeah, clinically. Not that I've done a lot of these myself, but certainly during training was sort of what we were trying to achieve as well, to ensure that we got around that margin. And again, that processing is really key, to emphasize that you don't want that fat dropout, just so you can ensure these DFSPs just have such irregular projections. So even just a small amount of fat dropout really degrades your sort of certainty about getting around it, I think.
Absolutely.
Next, we will discuss recurrence rates following Mohs, micrographic surgery, and wide local excision for squamoid eccrine ductal carcinoma, a systematic review of 85 cases by Lindsay Collins' group. This review analyzed 85 cases treating squamoid eccrine ductal carcinoma, which is a rare adnexal malignancy that often mimics squamous cell carcinoma and is frequently misdiagnosed on superficial biopsy. Specifically, it compared outcomes from Mohs micrographic surgery and wide local excision. Interestingly, recurrence rates were nearly identical, about 19% for both Mohs and wide local excision, with no statistically significant difference. Metastasis occurred in roughly 9% of wide local excision cases, and that was rare in Mohs micrographic surgery groups. Despite this, squamoid eccrine ductal carcinoma remains aggressive, with historically reported recurrence rates as high as 70 to 80% and metastatic potential of up to 50%, far exceeding what you typically see in squamous cell carcinomas. So why the no difference here? Likely limitations include small sample size, short follow-up, publication bias, and frequent misdiagnosis delaying definitive treatment. The takeaway: early, deep biopsy is critical for these lesions. And while Mohs surgery offers margin control and tissue preservation, current data don't clearly show superiority over wide local excision. Close long-term follow-up remains essential given the tumor's aggressive behavior. I've not seen many of these clinically, so I can't speak from much personal experience, but have you treated these? Do you have any pearls for us regarding, sort of diagnosis, treatment, and why we may not see a difference here with wide local excision versus Mohs surgery, which is so contrary to many of the tumors we do treat?
Yeah. I mean, I don't think any of us see a lot of them. When you practice long enough, you've seen enough of them, and you've had patients that have succumbed to them. They scare me. These, eccrine malignancies that can kind of be even a little bit bland histologically, and then patients present with bone pain a year later, and it's metastasized to bone, and there's not really much in the way of systemic therapy. They don't respond to immunotherapy. They don't respond to traditional chemotherapy. There's some people that think because of the eccrine glandular nature, it can respond to some of the agents we use for metastatic breast cancer, but even that data is not hard and fast. They just need to be followed closely, even again if it seems relatively bland when you excise them or do Mohs on them. I think if it's not on a cosmetically sensitive area, if it's on the torso or the extremities, I would almost prefer to do a wide excision with a 1 to 2 centimeter margin, as opposed to just Mohs with smaller margins, just to ensure a nice significant substantial margin around the tumor margin. But it's one of those things that is so rare that we just don't have sufficient numbers to really have a unified or systematic approach to them. And for sure, they can behave aggressively, and they can metastasize, and they can kill patients. So just be on the lookout and treat them, thoroughly. This is not a tumor where you want to just get a 1 millimeter margin around because it looks kind of, bland. They can really behave aggressively. So
when you are doing Mohs surgery, does that sort of equate to like a 5 millimeter launching point around where that clinical lesion is, or how do you approach that from a logistical perspective?
I think 5 to 7 millimeters for that first stage is reasonable if you can do it. If it's on a cheek, a forehead, a chin, sometimes when it's on a eyelid or nasal ala, that's not possible. in areas there where the skin is so thin, the tumor sort of has access to things like lymphatics and vasculature a lot easier than when it has a big, thick adipose layer between those structures and the tumor. So yeah, we've had some bad outcomes with these tumors. So I'm always a little bit wary of them when they come along. Luckily,
Absolutely.
most of them do fine.
Well, thank you for impressing upon us sort of the somewhat and at times grave nature of this diagnosis. When you say close clinical observation and follow-up, what does that look like to you? Like, are you seeing these patients every 3 to 6 months? Or, is that entailing lymph node exam with each? Are you getting any regular imaging, or how do you approach?
Again, it is a patient. They're so rare that it becomes a very individualized plan. But at very minimum, we see them back, and we see them back for a long time. When we treat a bad squame or a bad Merkel cell, I think when the patient makes it to 2 years, they're generally going to be okay. And when they make it to 3 years, it's almost unheard of that there's a bad outcome beyond that. But these patients can have recurrent or metastatic events farther out than that. And so I tend to follow them indefinitely. We might spread out the interval between follow-ups, farther and farther as they get further out from their initial treatment. But we just follow them closely clinically. They can recur to areas like bones, lungs, other internal visceral organs. There's not this common metastatic patterns like we see with other kinds of skin cancers. It's not like a squame that's almost always going to go to the lymph node first. I mean, they can go to nodes, they can go like to bone, to the viscera, to the brain. We've seen it happen in really unpredicted metastatic patterns. So just have a respect for them and see these patients back. And it's not like most of your Mohs patients where you say, okay, call me if there's a problem. Just follow up with them, and if they present with weird symptoms like bone pain or joint pain or things like that, have a lower threshold to image.
Definitely. Okay, wonderful pearls there. Moving on, we are next highlighting a practical surgical pearl in the management of superficial angiomyxoma, or SAM, a rare, benign, but locally recurrent tumor with recurrence rates up to 30% after standard excision. This this case report by Thompson et al. Describes the use of CD34 immunohistochemistry during Mohs micrographic surgery to better delineate tumor margins. SAM can be challenging intraoperatively because its myxoid stroma closely resembles solar elastosis, especially in the superficial dermis, making margin assessment difficult and likely contributing to recurrence. In this case, CD34 staining, after confirming positivity on the initial biopsy, helped highlight stromal spindle cells and vascular components, improving visualization of tumor borders during Mohs. The tumor was cleared in a single stage with no residual disease, and reconstruction was completed with a bilobe flap. Here, the takeaway was that CD34 can be useful in Mohs surgery for superficial angiomyxoma, particularly for defining peripheral margins. Just remember to confirm tumor staining on initial biopsy and consider using a normal skin control intraoperatively. Dr. Ibrahim, is special staining something that you frequently employ? Do you have any experience with CD34 specifically? And for someone who is practicing in an outpatient private practice setting, how feasible would it be to do these special stains on occasion?
I practice in an outpatient private practice setting, and we do special stains every day, almost entirely MART1. We have done both hand staining, and then more recently we have a very small, cute auto immunostainer. It's benchtop, and it does a great job, and it runs pretty quickly. And you can put whatever stain you want in there, so it's just a matter of which one you load in there. So we do Mohs for melanoma in situ every day. The auto stainer allows us to do immunostains within the flow of the day. So it's not like when we were hand staining, because it would take the histotech's full attention for that period of time. It kind of took them out of the rotation a little bit. With the auto stainer, it's set it and forget it. So we can just schedule our MIS is the same way we would schedule a basal cell, which is great. We do cytokeratin staining for aggressive SCCs, some of these poorly differentiated single cell tumors, and then less commonly for extramammary Paget's. Superficial angiomyxoma is a benign condition, so it's not something, I don't think I've ever done Mohs for that, but it can be locally infiltrative. So I think removal is important, but I think this is great because the histology is so subtle. So, though that immunostaining can really make a meaningful difference in margin control.
Absolutely. Yeah, I did note that it was interesting that they were doing Mohs surgery, even though it is a benign lesion. But I suppose in, areas that are cosmetically sensitive, you do want to make sure you're getting it and decreasing the risk of recurrence. I wonder how you would be able to bill that or justify that from a medical utilization perspective, but certainly in terms of providing excellent patient care, I think there is utility there. Do you use CD34 stains in your practice?
No, I'm trying to think. No, I don't think we use that for any of the tumors that we treat. But I mean, like we do Mohs occasionally, maybe 2-3 times a year for like a desmoplastic trichoepithelioma. I mean, those can be infiltrative and invasive, and people want them off because they'll just keep growing. So, it's definitely not unreasonable to do it.
Next, we are highlighting a practical innovation for intraoperative decision making, a simple device to measure skin incision tension in real time, as reported by Dr. Q and team. As we know, excessive skin tension contributes to hypertrophic scarring, but until now, there hasn't been an easy intraoperative way to quantify it. This study introduces a low-cost handheld tensometer, essentially a modified lateral force gauge with dual hook probes that anchor into the dermis on either side of an incision. When released, the device directly measures the tension required for closure. In testing, the device showed excellent reproducibility with near perfect inter-observer agreement. Clinically, it helped identify the lowest tension closure direction, especially after subcutaneous undermining. The takeaway, this tool offers a quantitative approach to tension, potentially improving scar outcomes, guiding closure direction, and even informing suture selection. While more validation is needed, it's an elegant, practical step towards objective surgical planning in dermatologic surgery. Where do you think this would be of greatest utility? It seems like as a seasoned Mohs surgeon, I don't know if it would be as much of utility to you, but certainly thinking of some of our training and early career physicians, this could be super helpful.
Yeah, absolutely. It's trying to standardize or quantify something that most of us judge very subjectively, right? Our measurement for tension is just to look at it. But it's valuable, right? It could impact things like wound dehiscence and scar quality or functional distortion. Really, though, like you said, any surgeon with any most experienced surgeons are going to be able to have a good sense of this just by looking and feeling the wound and feeling how the edges move and so forth. So does it add value beyond surgical judgment, or is it really standardizing it for maybe less experienced surgeons early on or in training? I think that would be great. So I think it's fantastic to be able to quantify this, but it's not like it's something that's going to be widely adopted.
Agreed, definitely. But I did think it was a nice and somewhat novel thing to utilize, like we mentioned,
Absolutely.
especially for those
it's
who
a
are
great study.
who
Yeah.
yeah, who are sort of determining how to pinch and feel and close things with the least amount of tension. And finally, we will close with our last rapid review in Pearl, discussing a practical update to scar assessment in dermatologic surgery, a modified clinician-only scar score for retrospective analysis by Hager et al. The traditional SCAR scale is a 15-point tool that includes both clinician and patient-reported outcomes, like pain and pruritus. But in many retrospective studies, especially those relying on photograph, patient input simply isn't available. This group proposes a streamlined 13-point version, removing patient-reported components while preserving key clinician-rated domains like scar spread, erythema, dyspigmentation, track marks, hypertrophy, and overall impression. In validation, the modified scale showed excellent internal consistency with Cronbach's alpha of 0.9 and good inter-rater reliability across reviewers with varying levels of training. The takeaway, this simplified SCAR score provides reliable, standardized tool for retrospective photographic analysis, helping improve consistency in outcomes research when patient-reported data are missing. Have any thoughts on this last article as we're sort of finishing up here?
We do a lot of clinical research, and when you're doing a lot of cosmetic clinical research, and there's no good standardized measurement really for anything based on pictures. Nothing is perfect. So I think any effort made to standardize things is a step in the right direction. Standardization really helps research a lot, especially when you want to compare study to study, not necessarily within one study. But I also think not capturing the patient experience is a big drawback. I mean, I think how the patient feels and sees their scar is a very important component of scar assessment, right? Because we all see this every day where the patient, there's some they're just not happy with. You're like, oh, I think it looks pretty good, but if it bothers them, it bothers them, and that's something that needs to really be addressed. So, losing the patient's perspective, I think, is a trade-off for having maybe greater standardization for scar evaluation. Photos have limitations, as we know, lighting, angles, you can't feel it, you can't touch it, you can't pull on it. But I think it's a good, valiant attempt to standardize when all you have is photos and you don't have the patient outcome. So I think in that sense, it's good. And those of us who do a lot of clinical research are always pushing for standardized scales for assessing blank, not that we can use so that we can compare different studies and different interventions. So.
Absolutely. Especially when available, I think, as you mentioned, like tactile feel and patient input is hugely important and should not be, foregone for this shortened scale. But when it's not available, at least there is something that can be, sort of implemented to continue to soldier ahead with those research efforts. Any final closing remarks for us, Dr. Ibrahim?
No, it's a great issue. Lots of great pearls and contributions to our field. I have a great time doing this. So great job.
Well, thank you so much for your contributions this month. I'm sure our listeners will very much enjoy your insight and expertise. I just want to share that listeners can hear additional commentary on the month's journal articles on the same podcast platform they are currently using to listen to us today. Additionally, they can visit asds.net/DermSurge-Digest for additional journal podcast content. Thank you to our listeners and thank you to the ASDS. Thanks so much.
Thanks, everyone.
Thank you for listening to DermSurgery Digest, the official podcast of the Dermatologic Surgery Journal. To access these featured articles, author videos, and much more, visit journals.lww.com/dermatologic surgery. To learn more about the American Society for Dermatologic Surgery, visit asds.net.